Right. So if you can please settle down. How do we hide this for more? More, and then hide. Yeah, that one. So let's start with the next one, which is the esophagus. You've got a break coming after this session, so don't worry. Again, my mantra, anatomy plus pathology makes radiology. So let's go back to the anatomy. You know, the upper esophagus, there is a territory, I call it the ENT territory, and then the gastroenterology territory. So there is a bit of overlap at times. And of course, all of you gastroenterologists go through the ENT territory to get into your own territory. So a bit of recap of the neck part of anatomy. If you see here, this is a sagittal midline, and this is the mouth, the tongue, this is the nose. Posteriorly, there is pharynx. Pharynx has got three parts. The portion which is behind the nose is known as the nasopharynx. The portion which is behind the mouth is the oropharynx. The portion which is behind the larynx is the hypopharynx or the laryngopharynx, whatever you want to call it. So all of this is pharynx. And this is oropharynx, which we see as a GP or a ENT specialist to look for pharyngitis or tonsillitis, etc. Now, this is, let me change my mouse to a laser mouse. This is the lid of the larynx, which is the epiglottis. So when we swallow, this lid covers the larynx, and the larynx is in continuity with the trachea. So please remember, trachea is anterior and esophagus is posterior. So respiratory anterior and gastro posterior. Now, this region, technically, the books tell you that esophagus starts at C6 level. This is what a book will tell you. So this is C1, C2, C3, C4, C5, C6. This is C6. But anatomically speaking, to differentiate between hypopharynx and the larynx is not possible. And it all depends if a patient has done this, for example, taken a deep breath in, everything goes down. So we don't bother about it. But generally speaking, there is a landmark there. What is the landmark? Landmark is this cartilage. This cartilage is a complete ring. This is the lowermost cartilage of the larynx, which is known as cricoid cartilage. So inferior to, you must have heard this name, precricoid carcinoma. So technically you are in the esophagus there, but practically it might be in the ENT territory. And your territory then starts from here downwards. So this is esophagus. Now, on a plain film like this, a lateral X-ray, in this one I have selected one in which there was a lot of air in the air column. So you can stretch your imagination. This is the nasopharynx, and this is the oropharynx, and this is the larynx, and this is the trachea. You can see this soft tissue, which is, where the esophagus will start. Stretch of imagination, you can count it. 1, 2, 3, 4, 5, 6. So you can say that the esophagus is starting from here, C6. On MR sagittal, same thing here. So this is Mr. Esophagus, and actually in this one, you can see a bit of air inside. On a CT scan, same concept. So, okay. We ask radiology, when we do a barium solo examination, we take, so the patient is standing like this, and we ask the patient to take a bolus of barium. Barium is in the mouth, and then we say swallow. When the patient swallow, we take a video out of it, and we can make stills out of those videos. And we get these kinds of views, AP and lateral. In a radiology exam, it is we grill our students on this. I don't think so. This is ENT territory. Having said that, as gastroenterologist, you should know the anatomy. So look at this. There is an anterior structure, anterior blindly ending pouch, and then is the posterior. And this thing is continuity with the esophagus. So the posterior one is the piriform sinus, and the anterior one is valliculi. How do they form? I don't want to overload you. This is ENT territory. But basically, this is epiglottis. Epiglottis has got a glossoepiglottic fold, which is attached here to the hyoid bone. And on the lateral side, there is pharyngoepiglottic fold. This is what we call supraglottis. You know, glottis or larynx in ENT world has got three parts. Glottis, which is true chord, supraglottis and infraglottis, right? This is supraglottis, so nothing to do with you. Having said that, on a barium examination, you should understand what is the anatomy. So anteriorly, if you see on a cross section, this is the glossoepiglottic fold. You know this one? Glossoepiglottic fold. So the barium is sitting here and the barium is sitting here. It is anterior. And this portion is known as valliculi. This V is valliculi. On the other hand, posteriorly are other mucosal fold, which is this aryepiglottic fold. Aryepiglottic. There is an arytenoid cartilage. And posterior to that is the piriform sinus. And the piriform sinus is posterior and is inferior. This is your neighbor, because from the piriform sinus, it will go into the esophagus, right? So it will go into the esophagus. I'll show you three DICOM cases. And so as I was telling you in the beginning that I don't have time to give more practice on this to you, but just one second. Can somebody help me with this? Uh, I just want to share this. So I have to unshare the Zoom. Is the meeting open? No. Okay. Let me then go back. Just one second, please. अच्छा इधर से I don't think meeting will be. Let's go.
Recording in progress.
Yeah. Yeah, okay. The only thing is that we were not. Those of you who are online, now can you just confirm that this is being? Yeah, we can see. Okay, just keep looking at this one in between, right? Where is hide? This is it. Okay. Yeah. Sorry for that. Now, this is what happens when we So the patient here is, this is a lateral of a barium swallow. The patient has taken a mouthful and is waiting for us. We say, please swallow. And when the patient swallows, this is what happens. You see here, uh, here you are, the bolus is going down and then it goes here. 1, 2, 3, 4, 5, 6. So somewhere here is the start of the esophagus. So this is how it happens. Now let's go to CT. Now this CT, can you please confirm it is being projected to online people? It is. So this CT is too complex for you. I am not, don't spend time. I put it for your workshop, but don't bother. I'm just going to quickly go through it. Now, if you see it here, now this is a sagittal and this is an axial. And look at the reference point. Now, right now we are at the nasopharynx, ENT territory. We are coming down. Here, this is the tongue, and we are in the oropharynx. Now we are going down. If you see the epiglottis, this is the Mr. Epiglottis sitting here, right? So we are going down. Now you can see those veliculi. This is the epiglottis, veliculi, the glossoepiglottic fold. And this is the piriform sinus. And as we are going down, you see this is the piriform sinus. And ultimately they converge into this, nondescript type of soft tissue. Here you are. 1, 2, 3, 4, 5, 6. So we are just at the junction of hypopharynx and the upper esophagus. As we go down, so we are at 6 now, right? 1, 2, 3, 4, 5, 6. And you can see, this structure is the esophagus. At times, there will be a gas bubble there and you will see it much better. These are the cartilages of the larynx. And as we are going down, look at this. This is the thyroid gland. Thyroid gland is high density because it contains iodine. This is the isthmus, right lobe, and the left lobe. You see this thing? Now, this is your territory, and I'm going to teach you in this session what is when upper esophagus, they are not going to deal with this at this level, ENT, you are going to deal with this. And I'll teach you what is the criteria of thyroid invasion. It becomes a T4. You cannot treat it. You cannot do surgery on a CT scan if there is a carcinoma of the esophagus. So if you see, develop your eyes on this finding because it's a tricky one. If you go back to the anatomy of the trachea, the posterior wall is sort of a straight line and it is not hard. So esophagus can sort of project in it. And that is why it becomes very difficult to call it a T4. T4 by definition here will be if it invades into the trachea. It's a game changer. If you say it's a T4, gone. You cannot do anything. And that's why at times you will advise another test, EBUS, etc., where the respiratory people can go in and see if it has gone. The main concentration on this session is going to be CA esophagus. So now we go to, from here, we are going to barium, rest of the barium. So of course, when we do a swallow, we trace it all the way to the gastroesophageal junction, and we also check for reflux. So here is the esophagus. This is the aortic knuckle. It goes all the way and goes into the stomach. We do it supine, and now you can see this air bubble. So you can understand, sorry, we do it in erect. So, and you can see this air bubble here means that this is an erect film. And please remember that's an exam question. They will ask you supine or erect, right? So if the barium is here, you call it a supine. So this is how it looks like on lateral, and ultimately we do films of this. Then we make, when we do a barium swallow, then we make the patient supine. We change a bit of oblique position, give the patient a bit of water to drink on the table. And the idea is to look for any reflux. So we can at times diagnose reflux like that. So then please concentrate on this one. This is the main part of this session. This is the CT scan of, of the esophagus. So during today, what I'm going to do is we are going to go organ wise. So this, so that you are not overloaded. Actually, in the abdomen, I've just selected a single CT, but in each session, I'm going to just teach you the relevant bit. Stomach only, then in the next one, small bowel, then the large bowel, then the liver, then the pancreas, that kind of a thing. Here, this is only one CT of the chest which you have got in your workshop. And this one is to just to concentrate on Mr. Esophagus. So we are at the neck. You can see these cartilages. Please remember that the laryngeal cartilages, as we age, they become more and more calcified. So, even in the last case, the neck case, it was not like this. Now it is very calcified. So that is normal, right? Uh, and now we are going here. This is the upper esophagus. Thyroid gland is coming into view. This is the thyroid gland. And now this is the esophagus. This is right lobe, left lobe. Actually, there is a thyroid nodule sitting there. Now we continue. We are going into the mediastinum. You see this? Please remember that esophagus is in the posterior mediastinum, right? So it is common sense. It is sitting anterior to the spine. And here you can see bit of a lumen. This thing, you see, this is the posterior wall of the trachea. And develop your eyes because this wall is flat, right? But it is not hard. There is no cartilage there. So there can be a bit of indentation. On the other hand, if there is frank invasion of a esophageal carcinoma, then it will be a T4 tumor. Now, just concentrate here. Now, as we are going down, we are going into the mediastinum. This is trachea. Please keep looking at the trachea and the esophagus. This is the arch of aorta. Now, Mr. Trachea is going to divide into right and left main bronchus. You see this? Carina. So this is carina. Now, this is esophagus. Take home point. Esophageal carcinomas can invade the left main bronchus. Left main bronchus. Esophagus is far away from the right main bronchus, right? So left main bronchus, and I'll teach you, because if it invades the left main bronchus, again it becomes a T4 tumor. You cannot do surgery, right? Now, on the other hand, now this is the left main bronchus, this is the esophagus, this is the azygous vein, this is the descending aorta. Now, lot of issues are with the aorta. If develop your eyes here, for example, on this slice, this is the descending aorta, this is the esophagus. You can see that there is a fat plane between the esophagus and the descending aorta. When there is a carcinoma and it encases the aorta, we call it a T4 tumor once again. You cannot operate. And on radiology, we are quite good. I'll teach you science. But here, you can see that there is fat plane. Look at this area, the angle between the aorta and the spine. Look at this fat. This has got normal fat. This fat is going to be obliterated. If it becomes obliterated, you call it a T4 tumor, right? Game changer. So then let's continue with the esophagus. Now here we are still going down. Now there is a cardiac chamber here. Yes. Which one is this? Which cardiac chamber? Excellent. Left atrium, which is the posterior most cardiac chamber, right? Left atrium. Can you imagine when I started in radiology, which is 33 years ago, we used to be taught to diagnose left atrial hypertrophy on a barium solid. Can you imagine? And we used to do a lateral film of solo. And if there is an indentation on it, left atrial ectopic. So, but for you, this is another area where this thing is sitting here. For example, if a esophageal carcinoma is here, I will teach you signs of invasion of the pericardium on a CT scan. Now, if pericardium is involved, it still becomes T4 tumor are divided into T4A and T4B. So it is bad news, but still surgical. You can remove the pericardium and you can remove the tumor, right? So, so areas of interest. What have? Yes, please.
How patients that you diagnosed with that big one there is sort of how many of them had that on echo?
Rubbish. Oh, this was a rubbish criteria. I'm talking about something 35 years ago, right? So, echo was not in the world. It was not available like this. This is what I'm telling you. So, but this also tells you anatomy because, it touches it and indentation. So, I think that is just for historic interest, I've told, right? So, so area of interest in esophageal carcinoma, trachea, left main bronchus, aorta, and Mr. Pericardium, right? Left atrium. Now we are going down into the gastroesophageal junction. Here, this is it, and this is we are passing through the what we call diaphragm, and then you can see the gastroesophageal junction. Please remember, I always tell that this area is very tricky on a CT scan, the gastroesophageal junction, and it is very easy to overcall things because if there is a bit of a hiatus hernia, you can call it and things like that. So please remember, CT is, you will tell us that there is a carcinoma, then we will do a CT, right? So this is you have to diagnose and we tell you that this is the staging. Don't go home with this idea that you can pick up a tumor there. Now, we also, so if I go here, so when we look for, we also can look at the sagittal and we look for thickening of the wall, etc. So there is a bit of role of sagittal and there is a bit of role at times of the coronal, particularly where it passes through the, you can see this. Let me make it bigger. This is the left crus and this is the right crus. Now it is passing through it. For example, there was a carcinoma here and it invades the crus. So you will see it better on a coronal and at times on a sagittal. If it invades the crus, it is T4A once again. Not a bad news because you can still do surgery, right? But left main bronchus, aorta, trachea, gone. That is T4B. Okay, so these dicoms are finished. I think I need some help. So if you can just come out of this and go to.
So you want to go present this?
Yes. Where is the Zoom? Yeah, this one. Hide it. Okay. So, okay, exam case. Few of these are total exam cases, spot diagnosis. This is exam favorite. Okay, Zenker's diverticulum, achalasia. You see, let me describe it for you. Uh, we are in the cervical region. There is one portion of esophagus. This is a double contrast, which is slightly dilated, and then the lumen becomes narrow, and this is the distal portion, slightly different. Within that, there is a sort of a jet. We use the word jet of contrast, which is going through it. If you stretch your imagination, something is sitting here, and the hole in the esophagus is smaller. And through that hole, things are going. Yeah. Think. Yes, Madam Radiologist. Yes. Web. Web. And by the way, we see them quite often. And for gastroenterologists, please remember this, Plummer-Vinson. This is your exam question. So you will see them in Plummer-Vinson. So if, on endoscopy, this is the type of picture. Basically, these are mucosal folds. There is no muscularis or anything. And the point is that if you see this one is as if it is circumferential. So the barium has got minimum, the lumen has decreased. So it is passing through with, we call it the jet phenomena, right? And on the other hand, this is just on one wall. Webs can also be, it is a shelf-like filling defect, linear filling defect on one wall. It all depends. But this jet you must remember, and this is an exam case. So, and these ones are on one wall, and they are projecting this filling defect there. Jane is here. You see them quite often, isn't it? Maybe once a month or more than that, or what? So it's not uncommon, right? Now, this one is Zenker's. So this is Zenker's diverticulum. Now, if you see this AP film, now I have told you the anatomy. These are the valliculi. This is the piriform sinus. This is the esophagus. And this is an AP film, and something is projecting here. You have to ask for a lateral to make up if it is anterior or posterior. So you do a lateral, and you can see that there is a diverticulum there. This diverticulum is known as Zenker's diverticulum. Again, an exam favorite. Zenker's diverticulum. Actually, uh, uh, take a picture of this one. Pharyngeal or esophageal diverticuli. So, Zenker's diverticulum is the most common. Posteriorly, usually on the left side, between the fibers of inferior constrictor and cricopharyngeus, and air fluid level can be there. And so this is quite a common thing. And in endoscopy, please remember, you can perforate it. It can be a nightmare. So you have to be very careful. So look at this picture, and this can happen like this, as if there is a collection or an abscess there. Actually, there is food there. But beware of this. This is an NG tube which has passed and just coiled there, sitting there, right? And then on a barium examination, a Zenker's diverticulum you can imagine that in endoscopy you have gone in and you can simply perforate it. And this one is an epiphrenic diverticulum, right? Epiphrenic means it is next to the diaphragm. You will see them diverticuli in GIT are normal. You can have in esophagus, stomach, small gut, large bowel is the most common. Sigmoid is the most common, and that is it's a surgical word, and because that causes diverticulitis and etc. So please, this diverticulum is usually asymptomatic, and this is sitting next to the stomach. Now, on a barium examination, why I am showing you, because of your exam. Now, how does mucosa of esophagus looks like on a barium exam? So if you see here, this is and it is, remember, it is featureless. The mucosa, you remember, I told you in the plain film, the mucosa of the stomach has got, that rugi, etc. Here it is featureless. Just remember that, because in the exam, you are going to get this. We use the word coarse granular mucosa. Coarse granular. So indirectly, there are ulcers, but deep ulcers are not deep ulcers. So when you do an endoscopy, I'm sure you can relate with that. So coarse granular means esophagitis, esophagitis. So and again, it's an exam favorite, esophagitis. And esophagitis can happen because of AIDS, Candida, and there is a huge diagnosis for that, for esophageal ulcers. Now here, for your exam, favorite of the exam is this thing, ephthoid ulcers. Ephthoid ulcers. Ephthoid ulcers are seen in everywhere, in esophagus, in stomach, in small bowel, in large bowel. Please remember the concept. It's a deep ulcer. If you go back to the differentiation between in the large bowel, UC and Crohn's disease, which one is a deep ulcer? Crohn's. Ephthoid ulcer is considered pathognomic in that sense for Crohn's. Remember this, and they are going to show you in the exam. If you see a ephthoid ulcer, call it a Crohn's, right? And they will ask you, why isn't it in a barium enema, for example, why isn't it UC? Because it's a deep ulcer. UC doesn't cause a deep ulcer. That is why Crohn's disease is deep, right? That is why it goes through the wall. It can then cause fistulations and blah, 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 right? We'll come back to that. So ephthoid ulcers are exam favorite. Yes, spot diagnosis. Excellent. So this is tertiary contraction, right? Dysmotility, whatever word you want to use. This is known as a corkscrew pattern. And these are old age patients, which can cause this kind of radiological features. Tertiary contractions in esophagus. Yes. What do you think? Okay, if it is left atrial hypertrophy, the left atrium should be sitting here, isn't it? There should be a soft tissue sitting there. There is no soft tissue. Agreed? But your thought was good, because even the aorta can cause that kind of an indentation. So I just want stretch of imagination. There is something wrong, right? Now, this something, if it was outside and projecting from outside, even on an X-ray, you should have seen something there. So where can it be? Inside. It can be in the wall. In the wall. And this is where when you will do an endoscopy, you know what you will find? You will find this kind of a thing. You will find that the mucosa is normal, unless it's a malignant thing. You will say, and I could see something, and you will go for next imaging, because you are looking, consider yourself, you are an endoscopist, and you are just seeing this wall, and you're saying something is pushing in. Then you will ask, so on a solo, it will look like this. On a CT scan, we can give you more better, now here, submucosal, it can be cancers, but when there will be cancer, usually you will find mucosa is also gone. But these ones are interesting, leiomyoma and benign tumors like nerve sheath tumor, hemangioma, lipoma, etc., etc. And I've seen lipomas, and interestingly, on a CT scan, we can diagnose them, because we can diagnose low density and upper GI discussion. This is a lipoma, end of story. No need to do anything. So I just wanted to show you this. Okay, exam favorite. Varices. If you see here, there are anacondas sitting there. These anacondas are what? These are veins. On endoscopy, you will see this, right? And this is a pathognomic appearance for an exam case of varices. Please remember that as an endoscopist, the varices can be in the wall and they can be outside the wall. The outside the wall you're not going to see. We can see them on CT scan, right? But the inside wall on a barium will be like this, and on an endoscopy it will be like this. So these are a few examples which I am showing you just for your exam, and this is another one. Jane knows it. So Jane, let them answer. If nobody answers, yes, Jane. Yeah, excellent, excellent. So this is a pathognomic exam favorite film. Once again, now what is happening? If you see here, this is the esophagus. Now something is projecting out, projecting out, projecting out, projecting out, projecting out. Where is it projecting? It is projecting into the wall, into the wall. It is projecting into the wall. And with that, there is a stricture here, stricture here. So this is known as intramural pseudo-diverticulosis. What is the know your pathology and make your radiology? So what happens here? It is a condition in which it is caused by dilatation of excretory ducts of deep mucosal glands. So within the deep mucosal glands, there are excretory ducts. In these conditions, the mouth it dilates. And on endoscopy, you might see this, you might see this, you might see this, but you cannot see the wall. And it is projecting out, out, out. So it is usually associated with esophagitis, reflux, etc. And there can be benign strictures. I'll come back to the benign strictures. So this is a pathognomic condition. And please remember that in some cases, even last month, I think we diagnosed one in which the mouth was so small that on endoscopy it was not visible, right? Where I think you just pass through it and you don't see it, but on solo we could see that it is going out. So intramural pseudo diverticulosis, where a barium can be more sensitive than your endoscopy, right? Classical FRCR 2B film, chest X-ray. Look at the mediastinum, normal, abnormal. Widen. Why? Yes, please. Dilatation. Excellent. Good thought. Of excellent. If you see here, there is something wrong here. There is a bit of lucency as in air, and then it goes like this, and part of it goes like this. So something is happening. This is achalasia, right? Achalasia is a spectrum of motility disorder. These patients present to you with, it's a chronic condition. And they develop a mega esophagus. It can be like this. The distal end, basically, it's a motility disorder. Where is the motility disorder? It is at the distal end. Please remember, the basic idea is that muscles are contracting and the sphincter is relaxing. So in motility disorder, something is wrong in that spectrum. Even that tertiary contraction was part of the motility disorder. This is in radiology, it's a favorite in the exam because they show you chest X-ray to pick it up, right? And then you can ask for a barium, and this is what you are going to get, a dilated stricture. This appearance, if you stretch your imagination, is known as rat tail stricture. Rat tail stricture, right? Oh, okay. Bird beak is absolutely fine. Horrendous. I have seen three cases here in my experience in Basildon where unbelievable. This is a patient, unbelievable. A patient absolutely fine, going to the office, in the car, was having coffee and just went into coughing and came with this. What has happened? Perforation. And this is you know Bohr-Haave syndrome. It is horrendous, and it is such a, if you see it philosophically, absolutely healthy patient. Just, and this can be a fatal. And I've seen three deaths here. And we used to do when I joined Basildon. So the esophageal surgeries was being done here. Later on, it just shifted to amalgamated center, which is Broomfield in our trust. So those of you who are listening from online, that we are in MSC Trust, which is Mid and South at Essex, and we have got three hospitals: Basildon, Southend, and Chelmsford, which is known as Broomfield Hospital. So these patients used to come to us, and middle of the night, I have done this study, and this is what concept I'm going to tell you. Which kind of contrast are you going to use? Critical question. So this one, say again, which contrast? Gastrographin. How many for gastrographin? A few. Any other ideas? Water. So gastrographin is water soluble. So your thought content, I think there is another word which you might be like to use. Hint, there is something else. Low osmolar. Low osmolar. Critical. This is a black and white pass or fail in radiology exam. So remember these concepts, that barium is the best contrast in GIT in the normal scenario because it gives you very good contrast. You want to evaluate esophagus or the stomach or the large or the small intestine. It is the best. Having said that, there are scenarios where you don't want to do it, particularly when in the abdominal cavity, you are worried of it going outside, perforation. If you are worried about perforation, for example, post-operative perforation, you don't use barium because if barium goes into the peritoneal cavity, it will just deposit there. It will cause fibrosis, long-term complications, blah, blah, blah. So take home point, don't use it in the abdominal cavity where there is perforation. In the esophagus, there can be two issues. Interestingly, if it goes into, because it is, if it goes into the mediastinum, it will not cause anything. It will get absorbed ultimately. Barium goes into the mediastinum, again, it will sit there and it will cause fibrosis, etc., etc. But if Mr. Gastrographin goes into the lung, this is high osmolar, it will cause pulmonary edema. End of story. So it is critical that if you use it in a suspected esophageal, because you don't know, these patients are in pain, they might aspirate. And if gastrographin goes in, if borium goes in, it happens, quite often with us. If a patient is old and frail, and during the solo examination, they aspirate a bit of barium. It goes into and we immediately see, wow, what is happening? Stop, and we have got a protocol with the AMU people. The patient is sent there, and usually the physiotherapist, etc., they come, and the results are quite good. Results are quite. Gastrographin is, it will go into the lung, and what will it do? It will cause pulmonary edema because it sucks fluid. It is hypertonic. Same concept, the surgeons love it in small bowel. When it goes there and it sucks fluid, it can be therapeutic, if it is subacute obstruction, it tries to propel it. So never use it. We call it the low osmolar. There are many types of low osmolar contrast media. Right now in our department, we have got, I think, Omnipaque, both of them. So this is Vesipaque and there is Omnipaque, right? Interestingly, I was just in a conference in London last week. Gastrographin has got a national shortage right now. And you might have seen. So what we are doing is we are improvising and using Omnipaque, and we are developing new protocols because of that in GI also. And there is a lot of technicalities because these things come under various kinds of concentrations to 270%, 370%. So you have to, but this is a take-home point, pass and fail type of a scenario. Gastrographin is also used by surgeons, as I have told you, that they will, what we do is we give gastrographin 100 ml. We take films. If contrast goes into the large bowel, there is no obstruction. Sometimes we do up to 24-hour films. And for perforation, gastrographin is used. Esophageal perforation, low osmolar is used. Similarly, in when, post anastomosis, for example, you are worried about, yes, please.
Is there any negative using the low number one in abdominal perforation instead of
No, no, the only thing can be the level of the concentration or the density of the contrast. That is why we love barium, because the density is critical. So at times you don't get that kind of density. Otherwise, there is no negative. No. So in interpretation, at times we find it difficult. So now we come to strictures. Esophageal, this is a benign stricture. Any other questions we can take in the break, right? Uh, any other stricture, this is a benign stricture of the esophagus. And you can see that this is smooth margins. I'll show you a malignant ones. And there are too many things which can cause benign stricture. This one was a psychiatric patient. What is the hint? Corrosive. This was post attempted suicide. And corrosives can cause this. But from your perspective, develop your eyes. If it is asked in your exam, look at the outline. Look at the mucosa. There is no mucosal destruction. Look at the outline. Outline is smooth. It is tapered, right? On the other hand, look at this one. This is malignant. In malignant stricture, may it be esophagus or anywhere in the gut, you see mucosal destruction on a barium examination. You see overhanging, we call them overhanging edges, overhanging. Look at this mucosa. This is destroyed. And you can see these overhanging edges. Let me go back and look at this one. This is smooth. And another one where you can see this mucosal destruction. The word apple core is also used there, apple core. And in the large bowel, small bowel also, you can get apple core appearance, as if you have eaten the apple here and eaten the apple here, right? So the differentiation between smooth and this. Now, last 10 minutes, and we are in the esophageal carcinoma. So please concentrate on this. This is for your day-to-day radiology. Key, you will diagnose it, right? You will diagnose it on endoscopy, and then you will ask for staging. So what we do is that for local staging, we CT. Everybody will have a CT. And please remember this concept that EUS for local staging is much better than CT. This is an EUS because it can tell you where, is it a T1, T2, T3, etc. But T4 world, CT is good enough. And our main aim there is to tell you T4. Because if I tell you T4, it's a game changer. You cannot do. But all cases of esophageal carcinoma in NHS, they also get a PET CT because there is a concept of non-regional nodal metaphysis. So consider esophagus, upper esophagus, middle esophagus, lower esophagus. Now, if the tumor is in the lower esophagus and you have got an abnormal node in the upper esophagus, this is counted as metastasis. Game changer, right? So if there is a lower esophageal tumor and there are metastases in the gastroesophageal junction around the stomach, we call it the lesser omentum around that, it's fine because they can remove the tumor as well as those mets. But in the abdomen, if there are nodes in the retroperitoneum, it is considered metastasis. So that is why all patients have a PET CT also. Now it's a horrendous tumor, curable disease 20%, 80% is, but there is a concept of neoadjuvant chemotherapy where they give that. And so please remember, unlike other gut portion, there is no serosa. What is serosa? Serosa is peritoneum, right? The visceral peritoneum. In rest of the abdomen, rest of the gut, as in stomach, small gut, large gut, there is a visceral peritoneum. We call it the serosa. It is synonym, right? In esophagus, there is no outer. So the outermost layer is the adventitia, and that is why it goes out. A T3 tumor will go into the mediastinal fat, but we are more worried about the T4. So I'm going to teach you about T4. This concept I have already told you, non-regional lymph node. So please remember that T4A and T4B, within T4, if it invades the pleura or pericardium or diaphragm, you can still do surgery. But if it goes into the, let's say, the trachea or the aorta or the left main bronchus, etc., this is non-surgical. Lymph node, I have already told you the concepts. Now, what are the CT signs of incurable disease? Tracheal invasion. Now, this was upper esophagus. This is trachea, and you can see that trachea is displaced anteriorly. Displacement of the trachea anteriorly is taken as one sign. Second sign is that you might see that the tumor goes into the lumen, right? So this is tracheal invasion on CT frank trachea. But what we will do is that usually whenever we have got doubt, we ask for a e-bus, and the respiratory, they get involved and they do, because it's a absolute, you have to give the patient the chance, right? So on CT, the disclaimer is that there are signs of T4 invasion, but sometimes they are frank, black and white, and sometimes we are slightly on. So we have to give that chance to the patient. So how do we go about it? In tracheal invasion, we ask for e-bus. In other invasions, we usually ask for EUS. Having said that, many times the decisions are based on CT. Why? Because they cannot go through the stricture. When they and this will happen with you also as endoscopist. Yeah, you cannot go through a tight stricture, and you will be guided by us that this is what is happening. You can look inside, but you cannot look outside, right? Now, if you see here, this is the left main bronchus territory. So this is the left main bronchus, and you can see it is displaced anteriorly, and sometimes you will see that it invades the left main bronchus. Here is aorta, and I showed you the normal, and one thing is that this is aorta, this is the vertebra, and you can see soft tissue in this triangle between the aorta and the vertebra. This soft tissue should not be there. So this is taken as a sign of invasion. And this is taken, I'll come back to the aorta in the next slide. This is taken as a sign of pericardial invasion. You know what? This is the left atrium, as I told you on the normal one. There is indentation on the pericardium, right? A bit of indentation, you can feel it here. And there is no fat plane between the tumor and the pericardium. So you can say that I'm worried about. And of course, the disclaimer will be, let's confirm it on a EUS. Having said that, it will still be surgical. They can remove the pericardium and they can remove the surgery. Now, this is that obliteration of fat triangle between esophagus and aorta. Now, this one, please concentrate here, because when I will teach you in pancreas will be at 6 o'clock tonight. So you will be dead. So this is a very important take home point. And so I'll always teach esophagus with pancreas, because it's a black and white world. T4, bad news. In pancreas, T4, you know what T4 is? When there is encasement of the SMA, superior mesenteric artery, or the celiac trunk. That is a T4. And you cannot do any surgery. And they are dependent on us. They will go, what we tell you, so a huge responsibility on us that this is T4. Now, in both cases, there is a vessel involved. In esophagus, there is a vessel which is aorta. In pancreas, the vessel is either an SMA or a celiac artery. Now, how do we say that they are encased? So interestingly, the criteria in aorta is different and the criteria in SMA is different. And this is why I teach them together so that otherwise you get confused. And of course, you will get confused at 6. So if you see this is aorta, we use the contact between the tumor and the vessel is what we are talking about. The tumor is low density. You remember usually there is fat there. Now, divided into, if I draw a line like this, and this will be, and I draw a line like this will be 90 degree, 90 degree, 90 degree, 90 degree. Are you with me? So this is the criteria. If the contact is less than 45 degree, it is not involved. If it is between 45 and 90 degree, doubtful. So we will say by our criteria, we are suspicious, let's do an EUS. But if it is more than 90 degree, it is probable, right? In this particular case, if you do an exercise, if I draw a line like this and draw a line like this is 90 degree, this is 90 degree. What do you think? We are more than 90 degree involved, isn't it? Somewhere between 90 and 180 degree involvement. Are you with me? If I draw a line from here to here, anterior portion is 180 degree, posterior is 180 degree. In this case, all of this is. So by our criteria, this is definitely involved. In the SMA, the criteria is 180 degree. It is slightly different. What happens is that this is a vessel here. This is a tumor. And if you see this interface between the tumor and the vessel, this is less than 180 degree. Agreed? So this is not involved. This one is just less than 180 degree. However, this one, if you see, it goes from here till here. So this is more than 180 degree. This is the vessel, and you can see the tumor is going more than 180 degree. So this is the criteria for SM. Okay. And last, this is a different case, but similar radiological features which we saw on the last one. If you see here, this is the aorta, and this is the tumor. You have to look for this fat triangle, and you have to look for this contact. What do you think? T staging and T4B, right? It is and even here, again, the next slice. So you can see this invasion, this is more than. So please remember it is less than 180 degree, but still it is invaded because the criteria is different. In pancreas, less than 180 degree, it's fine. So this is the difference between the two. Okay. Okay, let me show the last DICOM and then we take a break. So I go to escape, I think. Yeah.
Where is the document? Here?
Yeah.
Okay.
Just one second. So I'll just show you a case of T4 esophageal carcinoma,
This
and
is
then
pancreas. Below this number.
These cases are with you also. So we will, yeah, just one second. Yeah.
Yeah.
Okay. So let's go through this. This is a T4 tumor. So I have given you the diagnosis beforehand, but let's trace this esophagus. And if you believe me, if you do this endoscopy, you will send it to me. You will not be successful in doing this endoscopy. You will say that we could not go through it. CT state, you will say I'm worried about a tumor and tell me. You will have taken some biopsies. Now, if you see here, just concentrate. This one I am just showing you for reference, but you concentrate on. Let me go back actually here. Now we are at the thyroid. And as we go down, you can see this dilatation of the esophagus. you can see that there is air fluid level. And we are going into the mediastinum, continuing. Look at the trachea. Trachea gives you a reference point. And now you can see this soft tissue. This is, abnormal soft tissue. And now here is the left main bronchus and the right main bronchus. Left main bronchus, right main bronchus. So look at this tumor. Now, just on this slice, what do you think? What do you think about the left main bronchus? Invaded? What are the signs? The signs are that it is displaced anteriorly. One can argue that you can actually see a bit of it projecting here, but I'll show you a sagittal for this also. What do you think is happening to the aorta? Completely encased. Now you can see this triangle of fat. It is gone between the aorta and this. And then you can see this soft tissue which is going, one can argue that it is maybe 180 plus degree. So anything more than 90 is definite, right? So this is aorta. Now when we continue below. Sorry, I was going. Now we are going down, and even here one can see it was touching the aorta. Look at this thing. This is a lymph node, but there are others. I'm not concentrating on lymph nodes, and then we go into the gastroesophageal junction. So this is a T4 tumor. When in doubt, what we do is that for a left main bronchus, another technique which we do is that we go for a sagittal. Now, if you see here, this thing. Just concentrate on the trachea, and I am coming to the left main bronchus. Do you see? This is in cross-section in sagittal. Do you see this small bit of soft tissue? One can imagine that as if it is projecting inside. Do you see this outline? You will agree that there is a bit of this, right? So in another case, if this was the only finding, I would have called it, but I would have said that send to the respiratory for. But here, actually, one can see that you can imagine it has invaded the wall and is projecting inside, right? So thank you very much. This is lunch break, and we are going to convene at. Oh, sorry. I thought that. Okay. So 11:30. So 11:30 we are going to convene, and then there is only one lecture before lunch. Two lectures. So take double dose of coffee. And by the way, those of you, there is Red Bull is available here also. So go for it. Yeah. You will need that. Can you project the next slide, and we'll just keep it there and mute. The world can introduce yourself.
Yes, yes.
Without your video.
Morning. Hi, I'm Ben Cooper. I'm a course director here today and consultant gastroenterologist. Just wanted to introduce myself. I hope you're all having a good session. We're obviously incredibly lucky, to have the wonderful support here in running this from Dr. Sami Khan, internationally renowned for his teaching, and I'm sure you're all feeling that this morning. Hopefully a really well put together program, I hope, for you, which should be really useful for those of you, particularly those of you with a keen interest in gastroenterology. It's amazing actually how, as from consultant colleagues, how valuable it is having a good understanding of the radiology that we're coming across, and it can be really, really helpful, in our day-to-day clinical practice when we're doing that. So I hope it's a really good session. I'm actually on call today, so I'm afraid dipping in and out of it. So I just want to take this opportunity to thank Dr. Khan properly, and I think we've got a little something for him for all of his efforts. So just something little. So thank you very much. Please. There are some nice flowers and beautiful trinkets.
Thank you very much.
So I hope you have a good day. Enjoy the rest of the session, and we hopefully look forward to seeing your feedback and refining it for future sessions. All right.
Yeah, thank you.
Lovely. Thank you.
Thank you, Ben. Thank you very much. Very kind of you. And let's crack on. I hope it's can my IT team it is projecting online also?
Yeah.
Okay. So those of you who are online, now in this session, we have got two lectures. One is stomach and duodenum, and then is small bowel. There will be a 5-minute break between the two, and then we will head to the lunch break. So next 2 hours. Okay. Now we will go, I'll show you a CT of stomach and duodenum, a normal CT. Now, the idea is that during this course, those of you who are face-to-face, you have got this, in Paxbane images of the same, so that you can scroll on it now if you want with me, or you can do it later on at your homes. But the idea is that I have selected a single CT scan, and on the same CT scan, I am going to teach you, consider it one patient, right? On which I will teach you stomach and duodenum during this session, small bowel during the next, and then the large bowel, and then the hepatobiliary and the pancreas. So you are going to master CT, that is the aim. And please remember, if you don't know your normal, you cannot know your abnormal. So that's the idea. So this is a CT scan of the stomach and duodenum. Please remember that we have got 3 reformats. When we do, what happens is on PACS that the software gives you reformats in axial, sagittal, and coronal sequence. Usually, as radiologists, we learn everything on axial. So our axial anatomy is very good. Having said that, please remember that in your territory, which is GI territory, they're critical to go for coronal, and where needed, go for sagittal. And in difficult cases, of course, we see everything, right? But as radiologists, we have to see everything, and we change windows also. Window means that we go for when you have to diagnose a pneumoperitoneum. So this is known as a normal soft tissue window. or an abdominal window, whatever you want to call it. This is a default settings, but you have to change this window to a lung window, and some people also use bone window. So if I change it to a lung window, this is the lung window. Now you can see the lung very well. And suppose there was pneumoperitoneum, a gas bubble outside the lumen, we would have picked it up very well. So as a routine, those of you, particularly surgeons who are interested in acute abdomen, please remember that you have to change your window to be able to pick up pneumoperitoneum. We do it as a routine. And we also use another window, which is a bone window. So this is a bone window. And on bone window, we are just concentrating on bone. So we see everything in multiple planes and multiple windows. If you ask me what is critical for gastroenterology point of view, critical is that you have to see axial as well as coronal. Axial and coronal is critical. But there are points in which sagittal is going to be also critical, particularly things like rectum, etc. on a CT. Rectum is not very well seen on a CT. MR is the investigation of choice. Having said that, a sagittal will be the best sequence. So let's go through CT of abdomen. Now, the one which I have selected you, for teaching purposes, it's easy because I have selected a case in which there is a lot of abdominal fat. Fat is our friend on a CT scan, and fat is our enemy on an ultrasound scan. Because if there is fat is a horrendous. If on ultrasound scan we cannot pick up things on a, and we always write a disclaimer, suboptimal study due to patient's BMI, high BMI, etc. Because on CT, fat is black and it gives you a lot of contrast and everything is very well visible. I have been a bit cheeky with selection of this case. This case is a CT enterography study. So I wanted to teach you anatomy. So in real world, things are going to be more difficult. In this particular scan, what we have done is that we have given about, and this is how we do a CT enterography. We have given about 1300 ml of contrast between 60 and 90 minutes before the study. So the contrast has gone into the gut, into the small bowel, and in our case, it has gone into the large bowel also. So there is a lot of distension. If you see the fluid, if you see the sigmoid colon, it has got fluid. But the purpose was to teach you anatomy. So let's go back to CT of abdomen, stomach and duodenum in this case. So this is the esophagus. This is the gastroesophageal junction. We are coming into the abdomen. This is the lesser curvature. This is the greater curvature, lesser curvature end. Now this region from here to here, this is liver. This is lesser curvature. So this is fat here. This is the region of the lesser omentum, right? Lesser omentum. So which I'll show you in a diagram format, but there is basically fat there on a CT. Now, please remember that the first part, the superior most part, the fundus is sitting here, which is just below the diaphragm. And then as we go anteriorly, the antrum comes. Point to remember on a CT anatomy that antrum, the gastric antrum, is the part which goes from left side to the right over the spine. So you will see that it will start going to the right. It is going to the right. And this is the pyloric canal. And then we come into the duodenum. And then as far as duodenum is concerned, the first part of duodenum is D1. And then we go into D2. D2, remember, is the descending portion. And this is where I was telling you that this is the most important part for the gastroenterologist. Why? Because Mr. Pancreas, this is the head of pancreas. So landmark is the pancreas. Head of pancreas is sitting next to the D2 segment. So this is the pancreas. Here, I'll tell you the pancreatic anatomy in great detail when we reach that point. But this is superior mesenteric vein, superior mesenteric vein. It should be etched in your memory as a landmark for you. Superior mesenteric vein is this, and this feathery appearance organ is the pancreas. Portion of the pancreas which is posterior to the superior mesenteric vein, this one. What is this? Excellent. This is the uncinate process. So on the right side is the head of pancreas. And this head of pancreas is related to D2. Now just concentrate on D2. As I'm going distally, this is going to turn 90 degree to the left side. It has to cross the midline and go to the other side. So this is the D3. So I come back. This is the D2, and then this becomes D3. It goes to the other side. Now D4 is going to ascend up. It is going to go proximally. So let me trace it. So I'm going up. Here you are, and ultimately it becomes the jejunum. So this is the gastro-jejunal junction. And I think you can reach close to this point, or maybe at times distal to this point in through your endoscopes, but not in all cases. Now we will come back to the coronal, and you will see that these things are beautifully seen on a coronal. But here, another landmark I want to tell you is SMA. SMA. Now, if you see, this is abdominal aorta. So the method to learn the SMA is to trace the abdominal aorta as we enter. So I've gone into the thorax. Now I'm coming into the abdomen. As I'm coming to the abdomen, there are three vessels of interest for you, gastroenterologist, which arise anteriorly from the stomach. So just look at this is the aorta. Now, there is a first vessel here. This first vessel, what is this first vessel? Celiac trunk, celiac axis, celiac artery, whatever you want to call it. Celiac artery then divides into the splenic artery and the hepatic artery, right? So, but we are not tracing them right now. We are going to the next. As I go down, here comes the second vessel. This vessel is the SMA. So this is how you trace the SMA. Now SMA goes here. And do you see that SMV is on the right side and SMA is on the left side, right? On ultrasound, I'm not going to teach you ultrasound anatomy, but on ultrasound, we take it as a landmark because this artery is hypo, as in black to our eyes, and surrounding fat is hyper. So this is a landmark. Once we trace it, we know that SMV will be here, and we will know that the uncinate process is here and rest of the stuff is there. So this vascular anatomy around the pancreas is key. On ultrasound, it is so important that we teach vessels first and then pancreas. On ultrasound, pancreas is difficult to see. On CT, it is the investigation of choice. But the vascular landmarks are the main thing which you have to remember. Now,
Recording
and
in
you can
progress.
trace it and when you go back tomorrow, tonight, just scroll through it and try to remind yourself that what is what. That is what this workshop idea is about. So I come back. Now I'm tracing it backwards. So this is the gastroesophageal junction. This is the D4. I am tracing it backwards. And this is the D3. Now, this D3 then will go backwards. So it will ascend up. This is the D2. And of course, this is the D1. So this is how the anatomy works. Let's go to a coronal. So coronal is a key sequence. You must see a coronal as a routine. I see it as a routine. So this is gastroesophageal junction. This is the fundus. Now just concentrate on the greater curvature. So here you are. This is the greater curvature. This is the greater curvature. Let's go back to the fundus and curvature. So this one is going to be the lesser curvature where I am. So the fat in between the stomach and the liver, that is the lesser omentum. Gastrohepatic ligament. Gastrohepatic ligament. I'll come back to that part of anatomy. Now, this is the antrum. It goes and ultimately, you see, this is the pyloric canal. And then D1, we also call D1 as the duodenal bulb, particularly well seen on a barium examination. And this is the D3. So this now, you see here, the gastroenterologist in you, what do you see here? What is this line? CBD, excellent. And what is this? Pancreatic duct. So they go and they drain into the ampulla, right? This is the ampulla in the D3. And now this, look at this, you can trace it backwards, upwards. And so what is this? Right. So, extrahepatic biliary duct, anatomically speaking, something which is superior to the insertion of the cystic duct will be common hepatic duct. Distal to that will be the CBD. We will come to that particular point. In radiology, usually, particularly in ultrasound, we don't see the cystic duct. So many of the times when we diagnose a CBD is dilated, actually we are looking at the common hepatic duct, but we don't bother. It is. But if you are a purist, then you divide it into common hepatic duct, then the cystic duct inserts. Below that is the common bile duct. And there are so many variations, which I will tell you later. So if you trace it upward, what is this? What is this? So this is the cystic duct, and you can trace it all the way to the. This is the beauty of CT scan, that you can trace it up and down, up and front and back. So I'm a huge proponent of teaching anatomy on CT scans, but that's a huge subject. But we are known as the anatomist of this century, by the way, radiologist, and I am passionate about it. We can see anatomy which a cadaver will not do, because a cadaveric anatomy is all distorted, don't see things. So you have to see it on CT. I call it virtual dissection. So this is now, once you see an organ, also look at the neighbors. So you're looking at England and what is to our south and what is to our north and what is to our. Here, the main area of interest for you in this region was Mr. Pancreas and the vessels around it. And of course, then we are going into the mesentery. So this is a bit about anatomy. And please, even in the lunch break, just spend 1 or 2 minutes and scroll through it and to consolidate what I have told you. We'll come back to rest of the stuff. Now, I think I have to escape it. Yeah. Yeah. Okay. So DICOM done. Anatomy plus pathology makes radiology. So this is the gastrohepatic ligament we were talking about. This is stomach. This is the lesser omentum, and this is the hepatoduodenal ligament. This portion, anatomically speaking, is known as gastrohepatic or hepatogastric, whatever you want to call it. This one is hepatoduodenum because it is attached to the duodenum. It is an area of interest for anatomy because the epiploic foramen is there, and behind this is the lesser sac. Lesser sac is important for the exam, particularly in radiology exam. We show a lot of cases and things like that. You should have a clear-cut idea that this is the stomach, this is the peritoneal cavity, and this is the greater omentum where I'm pointing out. This is the transverse colon. And posteriorly, this thing is the lesser sac, and this is the pancreas. So pancreas is retroperitoneal, and from there, abscesses, things like that, post-pancreatitis, you will see them in lesser sac. So this is artificially insufflated, peritoneal cavity. To make this concept very clear on this diagram, this is the stomach. So here is the epiploic foramen, and this is the lesser sac. So it's a potential space. And this potential space becomes very important in the pancreas world because pancreas is sitting posterior to it. And so this is lesser sac. Now, this is a case of ascites. In cirrhotic ascites, they say that somehow or the other, it also, in many a times when there is gross ascites, the lesser sac, the epiploic foramen is closed, so the lesser sac is not distended. Somehow or the other, in cirrhosis, we see it more often. But here, the concept of teaching anatomy using pathology. So this is a cirrhotic liver. Why is it cirrhotic? In cirrhosis, what happens is that there is atrophy of some segments and there is hypertrophy of some other segments. Caudate lobe, which is this one, I'm not going to teach you anatomy today. I don't have time of liver, segments, etc. I cannot teach you. But I just wanted to highlight on a cirrhosis, what happens. The segment 6 and 7, which are the posterior segments, these ones, they become more atrophied, and there is hypertrophy of the caudate, which is the segment 1, and there is hypertrophy of the left-sided segment 2 and 3. The fissures, they become quite prominent. And then there is, the edge of the liver is slightly nodular. It's not a classical case to teach you cirrhosis, but I have got a few cases today, which I'll show you once again. Having said that, in this particular case, you can see the ascites, and this is pancreas, and you can see fluid here. And if I ask you, where is this fluid? Because of your anatomy knowledge, this knowledge, it is not connected to anything. This fluid, this is stomach, this is lesser sac, and kidney, and then will be the pancreas, right? So here you are, this is pancreas. So this fluid, by definition, has to be in lesser sac. So this is what we do in our exams. We ask the candidate, what is this? Where is this fluid? That kind of a thing. So lesser sac is quite, here you are. This is one example of a plain X-ray, which I just wanted to show you. You remember, look at the gas inside, look at the gas outside, and look at the gas in the wall. This one is a classical exam film for FRCR students. Here, you can see transverse colon here. You can see the stomach. There is gas sitting here. Abnormal, isn't it? This gas, and this patient has got A&E with pain epigastrium. So this patient had, previous pancreatitis a few weeks ago and has presented with what? What do you think? Yeah, but then what has happened? Why has he? So with an abscess, infection, secondary infection, right? So if you see here, look at the anatomy. Now, this is stomach. In this, oral contrast has been given. Then there is a bit of fluid. You can see this now. This is stomach. There is fluid here. Within that fluid, there is bubbles of air and fat. And if you look carefully, there is a bit of enhancement. Same thing on this slice. You can see all of this. So where are we? We are in the lesser sac. And this is what exams cases are made up of. We are in the lesser sac. It's a lesser sac abscess. So this anatomy is critical, right? So otherwise, I'm not going to be satisfied as an examiner if you tell me that there is an abdominal abscess. Where is it? Tell me. So this is lesser sac abscess. In acute pancreatitis, which I'll teach you when you will be dead. So let me tell you the take-home points in acute pancreatitis. Imaging, CT has no role in acute pancreatitis for the first 72 hours. Remember that. So acute pancreatitis is a clinical diagnosis. There is no role of CT because the role of CT is to diagnose complications of acute pancreatitis, and usually they are manifested not less than 72 hours after this. So we actually do this. When will you know, if you give me a call, you're a gastroenterologist or a surgeon. Surgeons bother us more. So gastroenterologists in A&E world are more benign. There are a few surgeons. Hello. Yeah, I can see he is very happy. So, so then I asked them, what will you do? I will scan it if it changes your management. Tell me when the system start this morning. Okay. Have you done MLS? Yes, it is raised, right? This morning. What are you going to see? And the answer is a blank. So please remember that in acute pancreatitis, you are worried about necrosis. You are also worried about infection and blah, blah. All of these things, they start on a CT scan up to anywhere between 48 to 72. The books will tell you 72 hours. And so then after that, what is your rate? There are two main aims as a gastroenterologist. One is necrosis because it tells you bit of prognosis, right? You can, classification, etc. is a huge subject. You are looking for non-enhancing tissue. And number two is abscess. Key thing is abscess. And you are looking for any air bubbles within that fluid. If there is one air bubble, I'll call it. This is our criteria. If there is one air bubble there, and this one is not a bubble, there is absolute horrendous. Because here comes the role of interventional radiology. Then what will you do? You will send it to interventional radiologists to drain it, right? But the surgeons bother us, but they don't do anything. So, yes, please.
What would be the for complications? The initial recommendations are do an ultrasound at least to see for the etiology, like gallstones, where we might have to consider the RCT.
Excellent, excellent, absolutely. So ultrasound I will accept, the CT I will not. And the role is to, gallstones, biliary system. Yes, please. Oh, this I did not want to. Yeah, the walled off means it is within an anatomic structure which has got walls, right? So it is in a way walled off, but it is naturally walled off within the lesser sac. So this is stomach. This is just a repetition. This is Mr. Stomach. And now you can see that this is D1, this is D2, this is D3, and this is D4. Please remember the size and shape of the stomach changes with volume of contents, position, inspiration, expiration. And this is pylorus. Okay, here is ephthoid ulcer. I just wanted to show you because they come in the exam quite often. Develop your eyes how a ephthoid ulcer looks like. If you see here, this is an ulcer. There is a crater. This crater is barium inside. And then there is edema. The edema is mound of edema, and which is not, etched with barium. So this is a classical ephthoid, ephthoid. So many. So there is a bit of differential diagnosis for ephthoid ulcers. Ephthoid ulcers can be anywhere in the GIT. Please remember, by definition, they are deep ulcers. They are deep ulcers. And if you see here, this is how it looks like on a profile. And non-steroidal also cause them in stomach. But what is the common thing? Crohn's. So think Crohn's. And in our exams now, bariums are coming less for the simple reason that they are not all that important. Having said that, they still ask. I'm sure in your exam they will ask you some barium. And this ephthoid ulcer should be in your mind. Ephthoid ulcer in the large bowel on a barium enema. You know, the barium is sitting in the crater and the surrounding mound is not etched in barium, and this is how it looks like. So this is ephthoid ulcers. Then we come to duodenum once again. This is the D1, this is D2, this is D3, and this is D4, and this is the junction. So we have covered this, and this is Mr. Pancreas. You can see SMV. Posterior to that will be the, the uncinate process, and this is head. And this duct goes with the CBD, and there is an accessory duct, which we will come back to when we do pancreas. Okay, here you are. So pancreas has got, if you go to embryology of pancreas, again to be covered later, but just to give you a heads up, it has got two buds, ventral bud and dorsal bud. And both of them have got names, which I will cover when we reach that point. And there is a lot of variations. And that is why this pancreatic, the classical pattern is shown on this diagram. Classical pattern is that this is what we call the duct of Wirsum. It goes with the CBD, and they together go into the major papilla, into the ampulla. And then there is a duct of Santorini, which at times, this is one pattern. There are many variations, and it will go to the minor papilla. You are more interested in this part of anatomy, you as a gastroenterologist. So this is the pancreatic duct. These are the measurements. First part is 2 centimeters, second descending part is 8, third part is 8, fourth part is ascending. Please remember that duodenum is retroperitoneal structure. And this is a classical exam question. Pancreas is retroperitoneal. Duodenum is retroperitoneal. The first part is in the peritoneal cavity, the first part, and rest everything is in the retroperitoneum till we reach the junction, where again it becomes, the jejunum becomes peritoneal. This is a case which is an interesting case. It came as, an alcoholic on a Saturday, Basildon Saturday night, where we received a lot of, A&E is very busy. The patient got kicked in the epigastrium during a brawl. I'm just teaching you anatomy here. And the concept of teaching anatomy through pathology. Now, if you see here, this part, which part is this of duodenum? D. So look at the neighbors. So the neighbor is the pancreas. So this is a D2, right? Now look at the wall, but surrounding the wall, you can see this ear, isn't it? You want to confirm it? Go to the lung window. You see, is it confirmed? This is the lung window. So why will you see air next to the duodenum? There should not be any air. Yeah, perforation. So you go to the next slice, and actually, if you see, this is the wall. It is not projected just on a single slice, but you can see a rent there. And this is, so by definition, if I report it, I'll say retroperitoneal air instead of peritoneal air. This is retroperitoneal because of the anatomy, right? This patient also has got some lacerations in the liver. Interestingly, this patient went from CT scan to the A&E and went out home, gone. And when we reported it, we said, oh, the surgeon said he's gone. Yeah, so the police went and brought him back because we raised the alarm, he is going to die. so he had to be brought back by the police. So alcohol actually he was fine, he was walked out. So you see here, So if I ask you in the exam, which part of anatomy is this ear? It is in the retroperitoneum. That was the learning point here. Now here comes wall thickening of the stomach and the bowel. Wall thickening, let me tell you, let me warn you that if you read a book, it will tell you anywhere more than 5 millimeter, or some people will say more than 1 centimeter is abnormal. If you ask me, do I measure walls? And the answer is I never measure walls. I eyeball them. Why? The studies which have been done are done on control patients. In these control patients, what they do is when they are doing a CT, for example, what is the normal wall thickness of a CT stomach? So you have, think like this, if there is distension of the stomach, the wall will be more stretched and it will be different, right? And if it is collapsed, it will be different. So in ideal control studies, what they do is, they give contrast. Contrast can be two types. Oral contrast can be two types. One is positive contrast. You should have this concept. Positive contrast is gastrographic. One is negative contrast. What is negative contrast? Water. Water is our friend on a CT scan. Actually, we don't like now. I'll show you cases in which, look at this, very good example. This one is they have not given any contrast, right? Here, there is gastrographin sitting, right? So they give contrast on the table in the CT scan and the stomach distends. And then they do a CT and then they measure walls. And then they write down in the books, this is it. In the real world, it doesn't happen. So we have to eyeball things, right? And we have to be on the fence at times, but we raise the issue. It's good to be prudent. So many of even my reports, I say that I'm worried about. Even in MDT, I will say I'm worried about. This might be wrong, but I've done my duty. That please do an OJD, that kind of a thing. Now, if you go into more details, once you say that the wall is thickened, in your exam, if they show you a case, it will be black and white. It will be real thick, like these cases. I'll show you. Then look at the attenuation of the wall. Attenuation means, is it slightly hypodense, as in watery, or more soft tissue? And the studies will tell you that more hypodense means gastritis or inflammation, and more soft tissue means tumors. In the real world, it's not easy. It's not easy. But having said that, it's a good. Just concentrate on this case. If you see here, look at this wall. It is thickened, and look at this. This is submucosa. Think like this. There is a mucosa which is enhancing. So the mucosa is just adherent here. Then this is submucosa, and compare it with this submucosa. And you will agree that this is more hypodense. It is more darker. So this is a case of gastritis. Actually, there is a localized perforation here. There is fat standing here. This one is a tumor, right? Bottom line is that even experienced radiologists will find it hard. Don't worry about it. But in your exams, they will show you what have I done? What happened? Can you?
Do you want the pointer?
Yeah, I just wanted the laser pointer. But the point is that laser. So edema is near water attenuation, inflammatory or soft tissue density is more carcinoma, lymphoma type of thing. Now here, I think it is more clear. You will agree that there is wall thickness, and this is thickened, and this is water density. This was gastritis. This is submucosal. So I'll show you an abnormal case, and just 1 second. I will, and okay, go back to the DICOM. This DICOM is with you. I'm going to show you an abnormal case. This case is Of course, the surgeons bothered us for this case, but genuinely this time. So, you know, in good old days, how practices have changed, that it was emphatic in radiology. A&E calls you, we have got an acute abdomen, can we have a CT? My question will be, has the surgeon seen it? No, they say, first have the scan and then we will see. So we'll say, no, wait, the surgeon has to say. And we have got a point there. You have to see it before we accept it. But generally speaking, practices are changing. So he's laughing, surgeon. So, uh, so surgeons are our best friends also. So if you see here, this is the wall, and then comes, you know, one thing which I forgot to tell you, to measure the wall. You remember there were mucosal folds, rugi. They are ridges inside. So you have to measure those rugis should not be included. But if you are not experienced enough, you cannot differentiate. Even here, where is the rugi and where is the wall? You cannot. So it's a difficult one. Having said that, if you see here, this is the greater curve, this is the lesser curve. Just concentrate here. And now what is happening? You see this? There is a defect there. Gone. There is a physical defect. And because there is, rest of the wall is enhancing, and you can see that there is a defect. With that, you can see perifocal fat stranding. Fat stranding is a sign of inflammation, but it's more horrendous than that. You can see this defect here, and look at the ascites, and look at the pneumoperitoneum. And this is the role of lung window. So do you see this air bubbles? That on a normal window, so the teaching is that you have to use the lung window, and some people use the bone window also for the same effect. This is the bone window, but that should be your routine, and you can pick up free air right and left. You see, this is free air. You see this thing is free air. It is not in bowel loop. So, and you can pick up right and left small bubbles here and there. So this is a case of pneumoperitoneum. And in this case, as we go inferiorly, you can see even fluid going all the way into the pelvis. Even in pelvis, you can see these air bubbles sitting inside. And if you want to confirm it, you can go to the other windows to confirm this. So this is a case of inflammation, or which has perforated it. So we go back. So T staging of gastric carcinoma. Now, please remember that stomach, what is the outer layer of stomach? Outermost. Say again, please. Serosa. What is the other name of serosa? Peritoneum. Which peritoneum? Visceral peritoneum. So please remember this concept, because people are not very clear. That peritoneum has got two layers, right? And the peritoneal cavity is surrounded by these two layers. One is the parietal and the visceral. Some of the organs of the GIT, they are just encased by the visceral peritoneum. We use the word serosa, but it is the same thing, right? Now, if you see the classification of T4 tumor, very, very interesting. In other words, the outermost layer, which you don't even perceive on a CT scan, is serosa. So if a tumor just goes outside, actually it has crossed the serosa, isn't it? It will become T4 by definition. Because once it becomes T4, microscopically speaking, it is in the peritoneal cavity. And it can spread right and left. And that is why they have stages as T4, right? Prognosis wise. So here you can see that there is a tumor here which has just gone. How do we say that it is T4? Just if we see it, we just call it. If it is confined to the wall, we will say that this is T3 or whatever. But if it goes beyond, if we see it, we call it a T4 tumor. So it's easy. You see T4, tumor invades the serosa, visceral peritoneum, tumor invades the adjacent structure. There is a particular pattern of uh, malignancy of the stomach, which is an exam favorite, absolute favorite in the exam. This is known as linitis plastica. The concept is that some of the tumors they cause, and gastric carcinoma, the most common cause of linitis plastica is gastric carcinoma. Second most common is metastasis, particularly breast metastasis. There is diffuse infiltrative pattern, remember that. And you will see, and it is a lot of fibrosis is going on. So you will see thickening. And on a barium examination, you will see loss of distensibility. On a barium examination, loss of distensibility is taken as a sign of malignancy, by the way, or a chronic fibrosis, because it cannot expand. So you have to develop your eyes, and I tell you that it is an exam favorite, linitis. So look here, look at this specimen, whole of the wall. When you look at it endoscopically speaking, you will not judge this. Yeah, for you, it will be not all that bad. But we will tell you that this is whole of, it is infiltrative. Remember that word, infiltrative. So linitis plastica, take a picture of this because I feel it is a very important differential diagnosis for you. Linitis plastica has got malignant and inflammatory causes. And I want you to remember gastric carcinoma and metastasis. And I want you to remember good old Crohn's disease as the most common. Here you are. Look at this. This is a barium examination. On this barium examination, you remember the good old rugi, etc. You don't see them. It is constricted, right? Actually, eagle eye radiologist will pick up something on this greater curvature. Anything which will give you brownie points, distinction points in the viva. It's a bit too much for you, but say again. Extension. Why do you say extension? Very good. Excellent. Do you see that there is a bit of calcification here? Do you see this calcification? Stretch of imagination. What is happening? This is all wall. From here to here is the wall. And within the wall, there is a bit of calcification, right? So having said that, if you see the rugi are destroyed, it is not distended. So this is the picture of linitis plastica. On the other hand, this is a case which came to the A&E with linitis plastica, unknown. This was his presentation, by the way. He was a healthy man, presented with perforation. And if you look here, there is horrendous amount of pneumoperitoneum. This is the lung window. He came to A&E. Now, if you trace the stomach, so this is the stomach, and look at the antrum. Do you see this? You will agree that this wall is thickened, this wall is thickened. If you look here, do you see this defect here at the greater curve? So this was a case of linitis plastica presented to A&E with perforation. Now I am going into a different differential diagnosis, which is gas in the intramural wall. Intramural gas in the wall. This one is a gastrographin. On this gastrographin, you can see that there is what we call gastric outlet obstruction, right? Now, gastric outlet obstruction, common sense is that it can be so many causes. For example, a tumor, or for example, chronic peptic ulcer disease, etc., etc. But that is not the point. The point is that you can see that there is distension. This was gastrographin, right? You can see, do you see this air halo? So develop your eyes on this one. This is known as nematosis. So I am developing your concept of nematosis. Nematosis can be in the wall of the gut. may it be stomach or small gut or large gut, usually it is taken as a sign of infarction, isn't it? Usually it's taken as a very serious. But the but is that it can be benign causes also. And one of them is in this particular case, though there is stenosis, but it's not ischemia. Don't confuse it with another entity which you will see, and these are horrendous cases. They will die usually. Emphysematous gastritis in diabetic, where the patient will fulminant gastritis with wall, and they will usually die. You will lose them. But this one is because of obstruction. So again, take a picture, and I want you to have very clear concepts about this, particularly the surgeons. Please remember, as everything which glitters is not gold, right? So every ear in the wall doesn't mean that this is something what we call of concern. The concept is whenever intraluminal pressure will increase, gas can go into the wall through the veins, and then from the veins it can go right and left. So this is mechanical. And there is an entity, we call it idiopathic, where the patient has got a particular condition where there are gas bubbles in the we call it nematosis intestinalis, and these can present with pneumoperitoneum, by the way, and you don't do anything. And the patient is, we call the patient surgeons, oh, pneumoperitoneum, open, laparotomy. They will say, patient is absolutely fine. What are you talking about? They will come to your office. Let's go through it. What's happening? And this is a very interesting one. I'm not going to teach you, but because I've mentioned it, the same concept, treat the patient, not the X-ray. And this entity, idiopathic nematosis intestinalis, is an idiopathic condition in which air bubbles are in the wall. And these air bubbles can burst and the patient can present with pneumoperitoneum, and they are absolutely normal. So this is one of them, but we can diagnose it on a CT scan. Now, these life-threatening ones are the causes which you are worried about. The life-threatening cause is particularly ischemia. So the take-home point now, this case was very interesting, unbelievably interesting. What has happened is, if you see this stomach, I am showing you a coronal. You can see all of this air around. You see nematosis? Now, if you see the small bowel is distended and a bit of nematosis, do you see portal vein gas here? You see this portal vein. So what is happening? The gas has gone into the portal vein and ultimately gone. Portal vein gas in the liver is usually taken as a very serious sign. This case walked into the A&E. Can you imagine? So what had happened was, and this is, I think, about 15 years old case. What happened was that he presented with signs of subacute small bowel obstruction. And so that the pressure increases, and that is the, know your pathology, make your radiology. So there is a rent in the mucosa, and from that gas goes into this, and the veins then take it right and left. So take home point is that at times gas in the lumen, gas in the wall might not be all that fulminant, right? Okay, another exam favorite is volvulus of the stomach. Now, here what is happening, there is a twist. Volvulus of the stomach are two types. Because they come in the exam, I am going to show you. This is a barium examination, in which what has happened is that in this portion there is a twist. So it has turned like this. This is known as organoaxial volvulus. This is the long axis of the stomach. When the twist is along the long axis, what happens is that the greater curvature becomes superior and the lesser curvature is inferior. This is known as organoaxial volvulus. Please remember, unlike the cecal volvulus, volvulus in the stomach are usually just incidental findings. They are, we see them so often. Volvulus is, and many of times these are sitting in the thorax. So you do a CT and you will see this kind of a picture where part of it is sitting in the stomach and part of it is this. You will only treat it if it becomes absolute 360-degree. In those cases, actually, maybe there might not be any role of imaging because they will, it will be terrible because anything they eat and they will just vomit. So volvulus, take home point, volvulus of the stomach. If I write that word, don't bother about it unless the patient is unwell, which will be very rare. You will see it just a few times in your career. This is known as organoaxial, and the definition is that the greater curve becomes superior. Usually the greater curve is inferior. In this case, it becomes superior. Look at this. This is the greater curve which has become superior. Then is the mesenteroaxial. I don't want you to overload you, in which the gastric antrum becomes superior. So this is the gastric antrum, and actually the twist is and the short axis. Don't over concentrate on this one, but I just wanted to highlight the clinical significance of volvulus. Look at this one. Half of it is sitting in the thorax, half it this. Patient is absolutely fine. Now, do you see a filling defect in this case? This is a single contrast study. Do you see something happening here? Right? So what can it be? Means there might be a mass sitting there, right? So you do a CT scan. And yes, there is a well-defined mass. Of course, there will be a role of, if I report it, I'll say, please do an endoscopy, right? But now, just to develop your eyes that this is a very well-rounded type of a mass. Any differential? Leiomyoma is a good one. Anything else? GIST, excellent. GIST, gastrointestinal stromal tumor, stomach is the most common site, right? I'll show you. So this is the concept of an intramural mass, and this is GIST. In GIST, what happens is, now this is a classical exam case for FRCR, where do you see that oral contrast has been given, and in here there is air fluid level in the stomach, but there is something else. This damn thing, this is necrotic exophytic GIST, this large one. This is all a GIST. Anything which is more than 5 centimeter, GIST can be benign and malignant. Our criteria is simple. Anything more than 5, we say the possibility of malignancy. We just call it like that. So you have to remember that GIST can have necrosis in the center, and this is exophytic type of GIST. This case actually perforated. This was in the pipeline for surgery, but next week after the scan, perforated, died. Just a quick about 2 operations. Billroth 2, just to develop your anatomy on this. This is stomach. So, there is no connection between the duodenum and the stomach, and this is a jejunostomy. So this is Billroth 2, which is visible here. And this is Billroth 1, where what has been done? Antrectomy and gastroduodenostomy. So just wanted to show you post-surgical appearance. Do you think this lumen is normal? If you see this film is slightly supine, this is slightly erect. This thing, whatever it is, there was air here, it has moved. Something is inside. What comes to your mind?